In this first module, we'll examine the concept of enhanced personal contact, people living with HIV who have documented and consistent engagement in HIV care using some best practice examples. The objectives of this module are to describe what is meant by enhanced personal communication, build capacity of health professionals on enhanced personal contact with PLHIV with inconsistent engagement in HIV care. And understand the importance of retention and care for U=U. Just a terminology update that appeared in PEPFAR's 21 Colombian pesos. PEPFAR is replacing the term retention with the term continuity of care, replacing the term loss to follow up with the term interruption in treatment, and replacing re-engagement in care with return to treatment. Most re-engagement efforts to date have focused on reconnecting patients to the system of care from which they disengaged. New approaches are needed to reduce barriers to care and engage the highest need people, such as those with social isolation, substance use disorders, and mental health issues. The remainder of these slides will detail some best practice examples of enhanced personal engagement from well-resourced and resource-limited settings. To achieve additional improvements in population-level viral suppression, we need to focus on those people with the most difficulty engaging in care. According to MSF, this requires structural changes in how we provide care. An MSF pilot is supporting re-engagement in PLHIV, South Africa, where disengagement from care was estimated as 23% disengaged at least once in a 2-year period. MSF introduced a comprehensive welcome back service at an ART facility, starting on the day of re-engagement. The welcome service focuses on the special needs of people living with HIV returning to care after being lost to follow-up. These people may be not on ART and have drug resistance. They may have advanced HIV disease and other issues which make it difficult for them to remain in care, such as psychosocial issues like depression and other social determinants of health such as social isolation. MSF's welcome service seeks to address these needs by providing both medical and psychosocial support. Medical support includes ensuring that people are on an effective ART regimen with rapid restart if they are not on treatment, and switching to second line if they have treatment failure, and management of advanced HIV disease. In terms of psychosocial support, the service offers a welcoming approach, intensified counseling and peer navigation. The service also includes active tracing of those lost to follow-up and immediate triage of walk-ins so that they are not left waiting. During the first 4 months of the pilot, 196 clients previously disengaged were identified, with travel being the main reason for disengagement. Of those, 87% returned for their follow-up visit and 78% were virally suppressed after 3 months from restart. MSF is also using a social media campaign, WhatsApp and Facebook, to reach out to clients who may have disengaged from care. The Department of Health in South Africa is also using components of this pilot in its new #WelcomeBack campaign. There was strong staff ownership but requires constant adaptation to address challenges. Despite local guidelines and risks of prolonged ineffective treatment, staff are reluctant to restart ART without blood results or rapidly switch patients to second line before solving adherence issues. Judgmental staff attitudes to defaulting patients also remain a challenge, requiring repeated encouragement of a welcoming approach. However, we acknowledge the need to address health system-related drivers to create long-term change. This is still a reality in many settings. As the HIV epidemic matures, health systems must evolve to meet the changing needs of high-risk patients who struggle to consistently engage in lifelong treatment. Rather than punishing bad behavior, health systems must adapt to respond to this changing epidemic. The Welcome Service shows the potential for facilities to adapt existing resources and staff attitudes to be more responsive to patients' needs, and especially in an environment of increasing trends of disengagement. South Africa's National Department of Health, in collaboration with PEPFAR and CDC, has launched the Scienza, or We Are Doing It, campaign in several hundred facilities in South Africa. The objective of the campaign is to make access to treatment quick and easy through innovation. For example, Bullybox smart lockers for ARV pickups so that people don't have to wait all day in clinic to get their medicines, SMS reminders, and improved filing systems to reduce waiting time. The campaign helps to guide individual people through difficult times in their lives and also includes the Man Bringing Men Into Care campaign to find the missing men. The campaign has resulted in declines in missed visits in clinics where it has been implemented. To conclude this section of the module, we will look at a couple of specific innovations from the Scienza campaign. Scienza rapidly improved site-level performance across several cascade indicators including HIV case finding, same-day ART initiation and retention. 2 clinics introduced SMS reminders for clients who have missed appointments, and the total number of clients retained on ART increased from around 8,000 to more than 10,000 over 6 months. Here is one client's experience who received a SMS reminder from the Pinetown Clinic after he missed his appointment. He was out of town when he received it. The 28-year-old student and part-time Uber driver initially thought the SMS must have been erroneously sent to him until he checked his clinic card when he realized that he was late for his appointment to collect his ART by 2 weeks. Realizing that message was indeed meant for him, he quickly replied to the linkage officer saying that he was out of town but had medication with him and was taking it. He promised he would come to clinic on his return. Finally, some quotes from a man who has dedicated his time to bringing men into care. "I know that men don't like to come to the clinic because they hate spending hours sitting in the queues. But most importantly, they don't feel comfortable with being attended to by a female health worker. Don't worry, my brother. Come with me to my office, and I can help to fast track you so that you don't spend hours here waiting to be seen by the nurse." In the second part of this module, we will switch to a different but related topic, that of staying in care for U equals U. U equals U means that people living with HIV who are on antiretroviral therapy, ART, and achieve a durably undetectable viral load cannot sexually transmit HIV. U equals U is a public health message endorsed by communities, CDC, the NIH, International AIDS Society and others. U equals U is also a powerful global movement, as Bruce will tell us later in this talk. Flashback 11 years to 2008 and the famous, some say infamous and certainly controversial Swiss statement issued by Bernard Herschel and colleagues that PLHIV on ART for greater than 6 with VL suppression and no sexually transmissible disease did no need to use condoms. Originally intended for local Swiss audience following 2 cases of PLHIV jailed for infecting an HIV-negative partner, the Swiss statement went viral, causing global consternation among the prevention community. At that time there is little evidence to support the statement. HBTN-052 study was underway, but there were no results and limited data for the Rakai observational study in Uganda that VL suppression and circumcision were protect against HIV transmission, and some cohort data from San Francisco and other places. But as it turns out they were right, and the data are now very clear that U does equals U. Staying in HIV care or retention in care can be defined as having 2 visits during a calendar year spaced 2 to 6 months apart with the HIV care provider. It is important for all people living with HIV to make these visits, not miss visits, adhere to their HIV medication and achieve retention in care. While this talk is focused on the prevention benefits of ART, the health benefits are clear with HIV, now a chronic manageable condition. PLHIV on ART with VL suppression can now expect to live near normal lifespans. But still a lifespan somewhat short of a person without HIV due to the chronic inflammation caused by HIV, even with VL suppression, resulting in an increased risk of CVD, cancers and other non-communicable disease. PLHIV also have other risk factors which may affect longevity. For example, they smoke more cigarettes and drink more alcohol than their HIV-negative counterparts. So what is undetectable? Definitions of undetectable vary according to the limits of detection of viral load machines. In the landmark treatment is prevention studies, sexual transmission of HIV was not observed if the viral load was less than 200 copies. In one study, undetectable was defined as 400 copies. In the context of U equals U, undetectable means less than 200 copies based on the clinical trials. So let's head back to 2005 when the HBTN study randomized 1763 serodiscordant couple to immediate or deferred ART greater than. This was in the days when we were still fussing over CD4 counts and when to start ART. So the study design, which took 2 years to develop, was ethical. While the primary clinic endpoint was disease progression or death, what Myron Cohen and his team were really interested in was the primary transmission endpoint of virologically linked transmission events. There were 877 couples in the deferred group and 27 linked transmission occurred compared to 1 linked transmission in the immediate arm. All participants were given immediate ART and study continued for another 4 years, at which time there were 8 linked transmissions. 4 in people who had just initiated ART and 4 who had detectable VL. There was 96% reduction in sexual transmission. Since 52, additional evidence supporting U equals U has come from the 2 partner studies and the opposites attract study. As we will see, there were 0 linked transmissions in these pivotal studies if the HIV positive partner was durably virally suppressed. Again, the studies defined undetectable as less than 200 copies, except, as I said before, the site in Thailand and Argentina in the opposites attract study used 400 copies. I didn't know until I put this talk together that PARTNER was an acronym. Partners of People on ART, a new evaluation of the risks. It as a prospective observational study which enrolled 1,166 different gay and heterosexual couples in 75 centers in 14 European countries between September 2010 and May 2014. To be enrolled into the study, couple had to have a VL, 200 copies, and be having condom-less sex. Phylogenetic analysis of polymerase and envelope sequences were used to determine linked transmissions. HIV-negative partner became infected. Some interesting background information for the study in terms of time on ART and time not using condoms. Early results presented in February 2014 before the end of the study, final results published in July 2016. 0 linked transmissions. Transmissions did occur, with 111 HIV-negative people becoming infected, 10 MSM and 1 heterosexual person. 8 of these report condom-less sex with other partners. 33% of gay couples and 4% of straight couples were in open relationships. Partner 2 extension, to April 30, 2018, after 8 years. Study was unable to find a single linked HIV transmission, when viral load was undetectable, even after 783 couples had sex without condoms 77,000 times. Over the 8 years, 15 HIV-negative partners did become HIV positive, non-phylogenetic linked. Opposites attract. Observational Prospective Longitudinal Cohort Study. 343 MSM and serodiscordant relationships. 2012 to 15. 18,600 condomless sex acts. 34% of the HIV partners diagnosed with an STI. 3 new HIV infections negatives. None linked to the primary partner. A bit more context about U equals U. The risk is 0, not negligible or insignificant, just 0. It's interesting that U equals U results are not affected by STIs. Remember that original Swiss statement specified no STIs. And at least in the opposites attract study the frequency of STIs was quite high at 33%. What about concerns of viral shedding in the genital tract? Between 8% to 16% of patients with undetectable plasma viral load exhibit detectable virus in semen or vaginal fluids. Individuals with detectable viral loads in the genital tract who maintain undetectable blood plasma viral loads do not sexually transmit HIV. Of course, it goes without saying that if VL is detectable or unknown, PrEP and/or condoms are the most effective way to reduce transmission. Finally, what about VL blips? We know that blips are transient increases in VL after VL suppression on ART. Reasons for blips include laboratory variation, concurrent illnesses, vaccinations, or transient bursts of viral activation. In the Swiss cohort study and US military HIV natural history study, blips were reported at 10 to 13%. So in the pivotal studies, blips must have occurred, but no Lyme transmissions occur. So the take-home message is that transient viral blips are not a cause for concern unless they continue over a period of time. So the U=U message applies only to sexual transmission of HIV. What about other transmission routes? While an undetectable viral load means the risk of sexual transmission is zero, it's not yet obvious whether the same premise is true for other transmission routes. For accident needle stick injuries, PEP guidelines differ across countries. US recommends PEP for accidental needle stick injuries even if the HIV positive person has an undetectable VL. UK does not. Does U=U for breastfeeding mothers and infants? Not quite. While clinical guidelines in high-income countries such as DHHS, and the European and British guidelines recommend against breastfeeding for women living with HIV, they also recommend that women with HIV who make an informed decision to breastfeed should be supported in that decision. What do we know? The PROMISE study South Africa compared Nevirapine infant prophylaxis to maternal triple ART in mother-baby pairs where the mother was HIV positive and infant born HIV negative. The study continued until 18 months after delivery or breastfeeding cessation, infant HIV-1 infection, or toxicity, whichever occurred first. 7 infants in each arm became infected, 0.57% and 0.58%. In a 2017 meta-analysis of 6 studies in low-income counties, postnatal HIV transmission was 1.08% at 6 months. So not zero. Over 750 organizations from 95 countries so far. K=K, Vietnamese, II, Spanish, Portuguese, H=H, Russian, Macedonian, N=N, Dutch, German, B=B, Turkish, etc. Finally, Dr. Anthony Fauci from the NIH validating the science behind U=U.